Good morning, distinguished colleagues. It is my deepest gratitude and honor to be introducing to you a relevant matter which talks about health policy and systems research to strengthen our field of rehabilitation. I don't know how many, I declare no conflicts of interest for any of the presentation content. So basically, there is a global action plan, which is strong and of the most interest for us, where everyone who needs rehabilitation services receive quality services to optimize and to maintain their functioning in everyday life. I don't know how many of you are aware, but rehabilitation became a key health strategy for the 21st century. And if we want to achieve the Sustainable Development Goal, it is necessary that all patients receive appropriate rehabilitation. We're talking about 1/3 of the global population. And this rate is increasing because of the aging of the population and also the chronic diseases. The World Health Organization is very well prepared. It produced guidance for rehabilitation where it addresses the quality of the evidence and most of the times strong recommendations, which means immediate implementation of all these activities. To the point that by May 2023, there is this historical resolution for strengthening rehabilitation in health system, which has been adopted by all WHO, World Health Organization member states, and even the regions. So what is ZIT Health Systems? It's a set of 6 building blocks, which includes the governance, leadership, information systems, financing, service delivery, human resources, which means our workforce, and then assistive technology and medication, all towards providing functioning to people in need of rehabilitation. And the main goal of this resolution is to provide or to have 1 billion people more under universal health coverage for including rehabilitation, which means that each country should have a baseline, and then from that with the goal to increase the number of people who are benefiting from rehabilitation. And for that, the World Health Organization has prepared a set of documents with clear goals, actions to be achieved in all these 6 building blocks. And I would like to highlight to you one of them concerning leadership. It's rehabilitation in the health systems, a guide for action, which will implement access, coverage, and quality and efficiency. This is a very rationalized, systematic process where it starts with the STARS program, which is basically assessment of the situation of rehabilitation in each country. Then it sets up an implementation plan, a strategic plan, monitoring, assessing the objectives, if they're achieved or not, and then implementing. So it's interesting because several countries already started that process. And this is the first publication of the situation on 9 middle-income countries. I'm very glad to know that now you are high-income country, but for us, for example, Brazil, we are not included. But what was the situation of these 9 countries? Rehabilitation is hardly integrated into the health systems. There is shortage of the workforce. There is lack of rehabilitation in the primary care, intensive tertiary care, and the quality is also not excellent in most of these cases. So I would like to share with you some of the Brazilian experience. Brazil, as you know, is a country of continental dimensions, but we do have a unified health system under the principle of universal health coverage, in which health is by law a system for all citizens. So starting by Sao Paulo state, where I live and my universities, we have a network of rehabilitation facilities that take accounts for 100,000 patients seen per month, which is a significant increase in service delivery. In the capital, where I'm located, our Institute of Physical and Rehabilitation Medicine is fully integrated into the health system. We are one of the leading high complexity hospitals in all Latin America. And I would like to give you an example how we address challenges. So, for example, in Brazil, we have 1 new case of stroke every 2 seconds. Only less than 1% of all these people reach any rehabilitation, and when they do, they come 1 year after the onset. If we think that a stroke is both preventable and treatable, and the amount of money that will be dispensed for these patients is increasing exponentially, and in low and middle income countries, we host the majority of deaths and DALIs related to stroke, for example, and by understanding that for each minute after the onset of a stroke, there are millions of neurons lost, billions of synapses that are destroyed, and kilometers of myelin shaft that are also destroyed, with an aging of that brain 36 years, just after one single onset of a stroke. Clinical manifestations are variable, heterogeneous, but when we're talking about the rehabilitation process, what we really want to address is train health tissue to take over or act on behalf of the injured areas. So we are talking about plasticity of the brain, which is a dynamic organ with the possibility to reorganize itself after that type of injury. So basically, it's both reorganization of neural networks, changes increased in the synaptic strength, and thanks to the advances that we have been addressing in technology, we can fully or more and more understand both molecular and cellular mechanisms in a more refined way. So, for example, we know by animal experiments that it's important to involve both aerobic exercise, resistance exercise, coordination, learning movements, so that different areas of the brain receive that plasticity that will reorganize that brain after an injury, for example. Not only that, but we know that enriched environment with social interaction also has a synergistic effect in this model. So with all that knowledge, we, together with the Ministry of Health, that's why it's a health systems policy research, we try to establish a pathway for stroke rehabilitation for our unified health system. We look for equity. We're not following guidelines from abroad. We are not giving the same standardized treatment. We assess every patient looking for specific rehabilitation needs and demands, and then for those we provide service. So for example, we know now predictive factors for recovery of the upper limb. So those with optimal or excellent, good prognosis, we follow them using tele-rehabilitation. They don't need to come to the hospital unless they have a complication. On the other hand, those patients with limited or poor prognosis, we early bring them to the hospital in an inpatient addressing. For example, this with a severe pain limitation on the arm, after a proper diagnosis of a calcification in the tendon of the subscapularis muscle, for example, after a single session, very precise targeted to that calcification, we were able to have full range of motion and recovery of that function 10, 15 minutes after one session. So this is how we optimize system. In this project, we are targeting for measuring some kind of plasticity. So within the blood serum, we assess the quantity of this protein called brain-derived neurotrophic factor, which is vital for the synaptic plasticity, cell persistence, neuronal development. And in stroke, we already know that systematically in several trials, this protein is diminished. And irrespective or with no correlation with the size of the infarction, for example. And these findings of the literature suggest that if we don't care to increase the amount of that protein, maybe the damage can be permanent. So our goal is to sort of precision-wise give the proper amount of intensity and exercise in terms of virality to increase that protein in the blood. We know that for that we need healthy muscles. And sometimes we know that, for example, 42% of all stroke patients start being sarcopenic 4 hours after the onset. So it's very important that we assess these muscles because we want them to produce the protein that will induce the plasticity. And sometimes the muscle strength is 5 in both cases, but you see in this case, the change in the fiber and also the amount, the quality of the muscle. So it's mandatory. We systematically assess in these patients. And also important to understand there are some polymorphisms that just one single change in one allele will produce 25% less of BDNF in the blood than if the person did not have that polymorphism. With this study, we were able in our hospital to purchase a sequencer, a machine that will measure all these polymorphisms and ancestrology as well. We also do, and I'm so happy that Professor Mihai showed, that shockwave is very efficient for destroying end plates, and it's somehow selective. And it destroys the end plate so that even though we reduce the spasticity, but at the same time can recover muscle. So we teach every medical student in our school, no rehabilitation with proper rehabilitation. But sometimes this plasticity, neuroplasticity, may be maladaptive. Maybe it's not as proper. It's just the central nervous system telling the person, the body, that the pain is too much and someone should take action. And sometimes there is more neurotransmitters on the synaptic cleft. The receptors over the postsynaptic membrane are open for a longer period of time. So this is just functioning. However, over time, these changes become anatomical, structural, and somehow definitive. So we take as an example knee osteoarthritis, how much of the central nervous system is amplifying the nociceptive stimuli because it's chronic, it's ongoing to the dorsal horn. So back in 2008, we asked that question. People schedule for a knee replacement. For example, in our hospital, it might take 10, 12, 15 years to get the knee replaced. We asked the simple question, how much of this neuroplasticity of the central nervous system is impacting in terms of amplifying, augmenting the pain response? And we know that the pain comes through the spinal nerves at L3, L4, S2. So we look for areas of hyperalgesia on those specific regions because the pain is coming from the knee. It's very easy. You do a pinch and roll maneuver. You can measure with the pain pressure threshold, but you will see that specifically on that area, there is erythema, extremely painful, and even with autonomic changes that could be easily, quickly reverted by addressing the spinal nerve at those levels. So for the same X-ray, you have a myriad of clinical findings. For this one, maybe a knee replacement would suffice. But for patients with a sensitization of a segment or thalamic level, it's important that you address in a different way. So again, in collaboration or working for the Ministry of Health, we are doing this study to try to systematize the treatment of knee osteoarthritis to make this system more intelligent, more rehabilitated, more functional, and reducing the costs. So we do a multidisciplinary approach with our team. Every member of the team assesses these patients. For example, we know that excessive daytime sleep sleepiness is much more important or present in people with osteoarthritis compared with healthy volunteers, and could suggest the influence of a poor sleep. Nutrition is essential. Sometimes you're prescribing an anti-inflammatory drug, but the food that the people are taking is completely inflammatory. So you should balance or at least assess. And we routinely use ultrasonography. It's interesting the amount of changes that could be easily managed and treated in a couple of weeks, and sometimes more than one injury. So it's mandatory that we assess those. We use the WHO pyramid, so every patient receives self-management educational programs, and just a few of them come to a specialized care in the rehabilitation center. Our comprehensive multidisciplinary educational program, so this ball, this fascia, are given by the Ministry of Health to our patients. They should perform 30 minutes exercise every day. If they cannot do it standing, they do seated, not seated. They can do lying down, but it's important that they do exercises every day. We teach them how to sleep. That simple educational program, short duration, only 3 sessions of 4.5 hours, produced produced a long-lasting effect, significant reduction in pain with the magnitude of effect of 0.77 in patients with chronic severe pain, and the effect of this educational program lasted 3 months. Interestingly enough, there is a similar study in Denmark. This is implementation science. They treated 14 Denmark patients using an educational program plus supervised exercises, and they demonstrated not only decrease in pain, but at the same time increase in functioning that lasted for 12 months. This is group exercise or group teaching education, not individualized. And this is important because this hypothetical cohort done in Australia, over 61 patients, demonstrated a substantial cost savings. So we need to be innovative, and we need to do something to help our system to be more efficient and address people in more need, and those who are not, you can do a different way. For those who do not improve, we do a paraspinous block using a local anesthetics at the spinal level, which is affected. For those findings of tendinitis, bursitis, if it's superficial, we do radial shock wave. For bone marrow edema, we use focal shock waves. In this protocol for the Ministry of Health, we also assess the brain. It's interesting because people with knee osteoarthritis, chronic pain, they have an increase in beta waves on the brain in some areas, mimicking a little bit of fibromyalgia. And we believe that's very important because not only functioning, but we have demonstrated the structural decrease in gray matter in various areas of the brain. So it's important to identify those because then we can inform brain target rehabilitation strategies. In fact, 11% of the included patients in this trial for the Ministry of Health did not improve with all that escalation. So we used a transcranial pulse stimulation protocol. It is shock waves applied using neuronavigation through the brain. So this was a pilot study. This is the protocol. It has just been published. You do in the whole brain some areas. It lasts 30 minutes, the entire session. It's 1 per week for 6 weeks, consecutive weeks. And we demonstrated a significant reduction of pain. Some patients 1 year without pain and even with weight loss. Of course, you need to increase the generalizability of these studies, but we did not have complications, improvement in pain intensity with long-lasting results, so it could be promising. Let's investigate, hopefully together. The genetic profile is very important because people with polymorphisms of the receptor, of the opioid receptor, and also BDNF also respond badly. So those should be targeted maybe more intensively or faster. So to end, just to not see one knee, but see a patient. I think PRM physicians always do that. We see people as a whole because we not only address the amount of impulses that are going to the central nervous system, but also hence increase the suppressive pain system. We should act now, so we hope we build bridges. We would like to invite all of you to Brazil, to Rio de Janeiro, and hopefully Bulgaria, Italy, Turkey, and Brazil, we could collaborate together. If this is possible, why not? We want to live in a world in which all people in need of rehabilitation receive quality services to optimize and to maintain their functioning on their daily activities. It requires balance, strength, cognition, so it is possible. Let's try to do it. And on behalf of the entire University of Sao Paulo Institute of Physical and Rehabilitation Medicine, it's a big team of researchers, students, PhD students. We would like to really thank the Bulgarian Association of Physical and Rehabilitation Medicine and celebrate together with you your 10th anniversary. And maybe I call Professor Papanassou and Dr. Rositan for a little gift from all the international speakers. Thank you so much for your kind attention. Congratulations.
Thank you for your brilliant. Thank you.